Welcome, everyone. Thank you for joining us today. We're excited to spotlight this powerful example of cross-sector collaboration that's changing patient care in Bexar County. Like Jackie mentioned, this session's titled Bridging Medical and Social Care, University Health and Family Services. In this session, you'll learn how University Health has developed an innovative model to deliver tailored case management for patients with non-medical needs through a partnership with Family Services, a trusted community-based organization with over 120 years experience supporting families across the region. What makes this model unique is its deep integration. Family Services is embedded into University Health's electronic health record system, making it possible for clinical staff to seamlessly refer patients, coordinate your support, and track follow-ups, all within one shared system. Since launching in October 2023, this collaboration has supported over 160 patients and initiated over 170 care pathways related to food, housing, transportation, and financial stability. You'll learn from this approach more than just referrals. It's about improving care planning, strengthening follow-through, and improving health outcomes by addressing the root causes of poor health. We're fortunate to be joined by Dr. Carol Huber, who's the Vice President of the Institute for Public Health at University Health. Dr. Huber leads efforts to promote health prevention, prevent disease, and extend life expectancy through partnerships, data-driven programs, and community engagement. She brings deep expertise in quality improvement, strategic planning, and health informatics, and also serves at the state with our Texas Value-Based Payment Quality Improvement Advisory Committee. With that, I'll turn it over to you, Dr. Huber.
Great. Thank you, Charles. Thank you, Jackie, and the entire team at the consortium for inviting us to be here with you today. It's really great to see such an amazing turnout of attendees who are interested in this topic, and we're more than happy to share the story with you. I'm joined today with two really amazing colleagues. First is Mary Garr. She's the president and CEO of Family Service. It's an organization that's been vital to our community for over 100 years. And Mary has just done an amazing job at the helm. She brings a lot of experience in healthcare administration, which has made this partnership really seamless. Also is Sarah Mohammed Ali. She is the Assistant Director of the Institute for Public Health with me here at University Health. She is the brains behind this entire program and keeps Mary and me kind of on our toes and just everyday operations running. And she is just an amazing person to have on our team. And thank you for organizing us today, Sarah. So if you could start the slides and we can go ahead and jump, I think to the next slide, but we really want to talk to you about how our health system is connected to Mary's organization to impact the health of our patients. University Health is also known as the Bexar County Hospital District. We are also 100 years strong in San Antonio, Bexar County. We are a comprehensive and integrated network. You can see some of the ways that we deliver care in our community. We currently have 2 hospitals, but expanding to 4 in the next couple of years, but have a large footprint across our entire county, both with bricks and mortar facilities and clinics, as well as mobile units and integration with the schools. We also have a primary care group. We have a nonprofit health plan called Community First Health Plans. It's really focused in the Medicaid program primarily, but serves all generations, including through Medicare and employee-sponsored programs. CareLink is our program that is a financial assistance program for those who are uninsured or underinsured, helping improve financial access to healthcare. So on the next slide, then, I'll talk about how we as an organization have begun to look at our community and, like you, focus on how we can address the significant health and social needs in our communities. And these 2 maps, I think, just tell a really clear story about disparities that exist and relationships between health or things like life expectancy and poverty. The darker shades represent higher volume. So on the left, with life expectancy, on the northern half of Bexar County, people tend to live longer, like 10, 20 years longer than those on the southern half of Bexar County. And you can also see then that correlation with poverty, where poverty is just much more significant and prevalent in those southern zip codes than it is on the north. And this is a disparity that we really try to aim to improve here at University Health, and as does Mary's organization as well. On the next slide then, you can see that we introduced the Institute for Public Health. This was a combined effort between our county leaders and our University Health leaders in 2022, because even though many of those disparities have existed for such a long time, it was the COVID pandemic that brought many of them to light. And we have launched our institute with a mission to promote health, prevent disease, and prolong life in our community. We focus on looking at data, looking not only at the needs, but also the assets and the resources of our community so that we can help connect those dots. Bringing together programs, people, services, places, both within our organization as well as with our partners outside of the University Health, so we can improve and address those community needs. On the next slide is where we really get into the non-medical drivers of health. One of the first things the Institute for Public Health did was launch a health equity team, a health equity plan, and one of those priorities is to address non-medical drivers of health. And we do that not as a simple referral system, but as how can we as an organization integrate these medical and social services. We really see non-medical drivers of health as something requiring a comprehensive multi-strategy approach where we're bringing awareness to our staff and educating our employees, our partners, others within the organization and community. We know that we need to address those immediate health needs of our patients because those are barriers to improving their overall health. We're adapting the care that we deliver by providing telehealth services, mobile units for those who may have transportation barriers. We're doing mail delivery from our pharmacy to help people have access to the important drugs that they need, and really being advocates for this issue in venues like this, as well as statewide committees like our Value-Based Payment Quality Improvement Advisory Committee, on which I serve, helping to educate policymakers, legislators about the opportunities to address these needs to further the overall health and goals of our organizations and improve the health of our patients. And so we look at CDC's model for social determinants of health and understand that we have to look at education, economic stability, social context in the neighborhood and built environment if we're going to make an impact. And so we decided to go out and to seek a partner who wants to work with us in this regard, and not just to be someone who can kind of catch referrals we send over the fence, but to really work with us, integrate with us, serve our patients, and communicate back to us the impact that they're having, and then we can measure and evaluate that on our side. So with that, I'm going to turn it over to Mary Gar to tell a little bit about her organization and how they fit into this.
Carol, thank you so very much. So as you can see with Family Service, our mission is all about working with individuals and families in our communities, helping them on their life journey, overcoming their challenges and barriers, and in helping to transform their lives, going hand in hand with them. We're also helping to strengthen our communities, specifically the health of our communities. How we do that is by working to address those social determinants of health or non-medical drivers of health through a trauma-informed care lens. We've been trauma-informed officially since 2014, although we worked very sympathetically and pathetically beforehand. But our work, without even realizing it back in the day, was all about SDOH and non-medical drivers of health. We are the oldest human service nonprofit in San Antonio. As you heard Dr. Huber say, the health district's been in place for 100 years. We have been around since 1903. We were actually created by the city of San Antonio, reaching out to community business leaders, asking for help to address some deep pockets of poverty that we had in our city. We still have deep pockets of poverty across our city, as you saw in the earlier slide. But with that, it was coming together to say, okay, let's find a way to give out money to people in need, thinking that if we gave out money to people in need, that will pull people out of poverty. As you so well know, if you don't address all the other underlying root cause challenges and barriers in individuals and families' lives, it's very hard for them to move forward on their own without some supports. So over the decades, without understanding it, the family service would work to add in programs, services, expanding their mission to address what we now know as non-medical drivers of health. So today we actually work across 14 counties in Texas. We've been 27 years in several rural communities here. Last year, we served almost 50,000 unduplicated clients and supporting almost 100,000 lives at this point in time for last year. Next slide, Sarah. So if you look at our organization chart, and the reason why I'm showing this, you saw the healthy people wheel on the earlier slide that Dr. Huber showed. We are actually structured in the healthy people framework. We have 6 departments. 5 of them are tied to those 5 pillars: economic stability, education, health and healthcare. We call it neighborhood supports rather than neighborhood and built environment, and social and community engagement rather than context. But you can see that alignment there. Our 6th department is our rural services department because they encapsulate all of them out in the rural counties that we serve in. But all of our programs and services align to one or more of the non-medical drivers of health tied to the healthy people framework, and everything that we do internally works to integrate those programs and services, just as we work to align those externally with our partners throughout our communities. Next slide. From there, as you know, again, looking at that earlier slide of the demographics across Bexar County, we work in those poor zip codes, those areas that have the biggest needs, are the hardest to serve, have the biggest barriers to overcome. So you can see our breakout in terms of gender, ethnic breakout, ages. We start prenatal, go through every phase of life until end of life. And then if you look at the income breakout, this is for 2024, 90% of the families we serve, their household income is less than $25,000. 2/3 less than $10,000, and 1/3 earn less than $5,000 a year, which when I started at Family Service, I was stunned and said, there's no way that could happen, but it absolutely is. These families cannot do it on their own without supports from organizations like Family Service and University Health. Next slide. From there, and as you heard, my background's in healthcare administration. So I spent decades working in hospitals and healthcare systems. And what I would frequently see is, we're working with patients and addressing their medical needs once they arrive into that healthcare system. When we're talking about non-medical drivers of health, that's already happened in their past. That's the downstream aspect that's occurred when we receive them. It's much harder to address those needs out in the community when they're arriving to us, dealing with what primarily is, has been a fee-for-service episodic care model. The average person in the United States spends about 100 minutes a year seeing a healthcare provider, whether it's a hospital, clinic, doctor, nurse, etc. And much as we want to in our healthcare systems be able to influence health from the outset and help on the wellness and prevention, we are really not structured and modeled to do that very well. When we do the wellness, it tends to be more on the physicals, the immunizations, etc. But if we're working with our patients or clients, we need to think about, where does health really happen? It's where we spend our time. It's at home, it's at work, it's at school or after school programs. That's where health is really occurring. Other huge influences of health tend to be if people have access to affordable, healthy foods, so such as grocery stores, and do they have transportation and the infrastructure to get to them? Do they have safe outdoor places to be physically active, which we know ties into mental, emotional health, etc.? Do we have culturally enriching learning environments outside of the school systems that people can access? Faith-based organizations, churches, temples, synagogues, etc. Huge impacts on health because they are trusted organizations that people will go to for help. Community-based orgs as well, like Family Service and others. We have the trust in the community. We have the deep-rooted relationships. We are working with them already. A lot of organizations are influencing health in the community without even knowing that they are doing so. So it's, how can we build that intersection across the health spectrum to understand that we are all working on health from our various lenses and the roles that we each have. Next slide. So in the history of this partnership, back in 2018, Family Service was able to work with University Health and starting to have some conversations because we share the same populations. We're working with patients or clients in the healthcare system and in the community that have, needs and challenges, just working it from different angles. We started having these conversations, building that relationship. We had some shared grants early on where we actually not only were receiving some referrals of patients to us, but we actually had staff that were going over periodically. But it was very small scale at that time and very focused on that particular grant. So it was more of a transactional relationship, not anything that would end up in the medical record on the scale that we have evolved it to. So fast forward, through the pandemic, continuing conversations and relationships, had an opportunity to meet with the University Health System executive team and see what could we do to work on expanding this. So first, they asked us to partner with them as they were building their own non-medical driver of health assessment tool. We had ours in place already for a couple of years by then, and we gave them feedback for English and Spanish, how best to present it, communicate it in ways that would be receptive to their patients as they were building this out. From there, then, met with Dr. Huber's team and worked to expand, what are other things we could look at? And as they were looking at that investment in the community to build up partnerships with their new institute, Family Service was a natural fit for that because all of our work is about addressing non-medical drivers of health. So from there, what they worked with us on is building not just a transactional referral partnership, relationship transactional piece, but building a real partnership and investing in Family Service to be able to do this work. Because it's one thing to refer a patient out from your hospital or healthcare system and hope the patient goes to that community-based org that you referred them to and hope that that patient then receives those services, but you don't get any feedback on it, versus a true opportunity. And you'll hear from Sarah in a moment about how we have this referral link, investment in the system itself, use of the system. So when a provider is making a referral, that they have confidence that that referral will be followed up with, the patient will be seen, receive not just one service, but a whole comprehensive set of review and services. And that gets documented back in the patient record so they can understand if that referral is actually following through and making a difference on clinical outcomes down the road. So at this point, I'm going to turn it back over to Sarah to talk through that partnership and how we've been evolving it. Still in its nascent phases, but we're working to grow and expand this over time. Thank you.
Sarah, unmute.
Sorry about that. Can y'all hear me now?
Yes.
Sorry. So at University Health, we knew that integrating medical and social care really requires an interdepartmental collaboration along with participation from our community-based organization that we're going to be working with so closely, Family Service. And so we launched a NMDOH task force within our health system that really had leaders from across the health system, including our quality department, ambulatory, our care coordination project, which really, leads this effort within our health system, as well as our information technology team who builds our EPIC profiles and manages our EHR. And we came together monthly up until the launch in October to really build out this unique partnership and fully integrate Family Service into our EHR system. So that's the unique component within this project, is that Family Service, we're not using Find Help or any other outside program like that to do referrals to Family Service. We actually fully integrated them into our electronic medical record system. They have the same access as one of our social workers so that they can receive referrals and document within our EHR all the work that they're doing. They're not co-located within our facility, so they don't have direct access in that sense to our patients, but they're able to go into those patients' homes and meet with them and work with them and still feed us that information. As you can see here on the right, it's kind of a breakdown of our task force, and family service was very involved in each one of those work groups. So we wanted to leverage features within our EHR up until really the release of this Compass Rose module, which is a care coordination module within our Epic system. Much of this work was documented in patient notes. And we all know that a patient note, it's hard to pull data from that, analyze that information. And so Compass Rose has really helped us with this. We're able to monitor, manage this information, all this information related to NMDOH. As you can see here, you can see staff members, all staff members within the health system can see the social determinants of health the patient is screened for, and how they screen, whether they screen positive, negative, or maybe they're just at risk for it. Staff are able to, document and see the work that's happening with the patient to address those social needs through these different pathways that are created. And so we developed 4 pathways within this Compass Rose module, which really kind of set the framework of how we're going to work to address food insecurity, housing, transportation, and financial. These were created by our ambulatory care coordination department. Again, they are subject matter experts. They manage our social work team, and so they know, what needs to be done with the patient in order to address their food insecurity, to connect them to transportation, housing, and financial resources. And all staff members, their care team can see what program or what SDOH need, in a sense, that patient is being worked with. Within Compass Rose, we've built out targets. So these are milestones or goals that we work with with that patient in order to address their needs. This can be anything from connecting them to options for food insecurity and dependence, confirming that they receive that food insecurity need, or community resource. Checklist tasks. Again, most of the time we would document in a patient note, connected them to food resources, or printed out a transportation application and provided it to the patient. Now, through checklist tasks, staff can mark off what exactly they did with the patient in a quantifiable manner, date, time stamped, and also document the outcome. Was it successful? Were they able to get that application submitted? Were they able to give that patient that application? And in addition to that, we're able to track community resources patients were referred to through a resource directory that's built within our Epic system. So if we send a referral to the San Antonio Food Bank, we can monitor whether the patient is using that resource, won't be using that resource. We have a unique relationship with the food bank where they'll actually even communicate back to us whether they accepted that referral or declined that referral. And again, all documented within this Compass Rose module that we can then pull this information and really quantify the number of referrals we sent, what referrals we sent, and the status of those referrals between the patient. When we first started this program, we really wanted to start small. We started off with our Transitions of Care program, and this is an internal care coordination program that really provides patients, one-on-one education when it comes to their health condition. They follow the patient through their discharge and post-discharge for 30 days, making sure the patient's connected to any follow-up care that they need. We first started with our congestive heart failure patient. Again, these are patients that had to have been admitted to the hospital for an exacerbation or a new onset for congestive heart failure. They're identified in the hospital, they're screened for SDOH or NMDOH, and then they are followed post-discharge, connecting them to resources as it relates to their medical needs, and now connecting them after that with family service to address their social needs, those NMDOH. We then, in March 2024, expanded it to include our LACE Plus population. This is a readmission score that helps us identify, the likelihood a patient will readmit. And so, again, this is a more manageable population. We have that great relationship between our acute setting and our ambulatory setting. Manageable size, and these patients all have the willingness to accept assistance and improve their health. And so we had these two cohorts launch, and towards the beginning of last year, middle to the beginning of last year, we also added our diabetes population. At the Institute for Public Health and University Health, we try to find those disparities when it comes to our patient population. So we reviewed data when it came to our diabetic patient population, and we found that patients that lived in a zip code with a high social vulnerability index tended to readmit more than not. And these patients don't typically have any additional case management like our transitions of care team. So we found this patient population to be a great population to kind of model this, again, idea of connecting a patient to family service to address their NMDOH needs and receive that NMDOH specific case management. We launched this program May 2024. And as you can see, these patients, they have had to have had a hospital admission and screened positive for at least one of the 5 NMDOH that we screen for as required by Joint Commission and CMS. So food, housing, transportation, interpersonal safety, and utilities. Once they're discharged, and they must have had a routine discharge, we have a group of community outreach specialists that reach out to the patient, check in on them, and then offer them the family service program. And if the patient accepts this assistance, this patient gets referred to family service with an EPIC for the family service case management and addressing their NMDOH needs. So again, all of our patients are screened for NMDOH within 24 to 48 hours of hospital admission. With this program, again, we really want those patients to get that warm handoff. So we always have a staff member from University Health do that warm handoff to family service. It's not just an automatic referral to family service. Our transitions of care team, as they're building their relationship with the patient, they're also talking to the patient about family service and connecting them to family service, letting them know, hey, a family service representative will be calling you within the next 3 days to offer you their service if you'd like assistance addressing your NMDOH need. Once the patient is referred over to family service is expected to reach out to the patient within 72 hours of receiving that referral. They must schedule an intake appointment with the patient within 10 days of receiving that referral. An intake appointment, family service has their own SDOH screening that Mary will talk through here in a moment to kind of determine their plan of action to address that patient's social determinants of health. Next, they'll connect the patient to resources and follow up to ensure resources were received and those needs were addressed. They'll document all of this information within a patient encounter in EPIC, our electronic medical record system.
Thank you, Sarah. So as Sarah noted, University Health System has their process for identifying their patients and then linking to family service. It goes through the system. When we receive the patient in our system, now we will then incorporate our own processes. We have something that we created called our Getting to Know You tool. We want to make sure that our patients, our clients feel very supported and welcome coming into our system. We incorporate into our tool the CMS Accountable Health Communities Health Related Social Screening tool, which I know many of you are familiar with. That helps us to collect the non-medical drivers of health, or SDOH, aspects of their needs. We also, because we are trauma informed in our work, we also use an ACEs screening tool to support us so we can understand the impact of any trauma that they may have encountered that might also affect how we work with them on their needs. And then other demographics that we capture as well. From there, we have an algorithm where we assess not just that patient, we look at the entire family dynamic, because with that patient, there may be things that are going on with the patient, or we call them clients for us, in their home environment that affect the entire family. There might be things we can do for the family that we can't do just for the patient, but could support the patient in their long-term health outcomes. So we use all of that in that process. We do home-based visits and checks as well. We do follow-ups and continue to track them as long as they need those supports and links to resources, either within our own programs and services or out to one of our community partners. With that, you'll see I noted that we have a check-in on you tool. So we have a formal screening where on a regular basis, depending on how long they are with us, we will do periodic check-ins to make sure, okay, have we stabilized them? Have we strengthened them? So that we can know, where their needs are and how they're evolving. Something that might have been stabilized when they first came to us may now be something that is not working well for them today. Things that were not stable for them may be strengthened now. So it's helping to make sure that that balance is kept while we were working to move them forward completely. From there, as noted, once we receive that referral in Epic through the electronic health record, we contact the patient, assess them. That home environment piece is critical. Therefore, from there, we provide those supports, those services, as I know, to link to internal, external. And then that next key point, again, is documenting back in Epic so that referring provider can actually see what's happening with their patient. It's not just a hand off to Family Services, a community-based organization. It is a true partnership where it is a warm referral piece there, and then that continuing dialogue going back and forth as long as that patient is within our services. And when they come in, even if it is beyond a need that was in the original referral to us from University Health, if we identify other needs that might not have come up, because sometimes patients don't want to admit that they've got challenges or needs. It takes time to build up some of that trust, or they may think that that's just their normal and that they can't be helped in it. We can help to learn this as we're building that relationship with that patient and their family to see what can we do, not just to meet the immediate needs, but what can we do to help prevent them from recurring. And ideally, if this is an intergenerational challenge, what can we do to break that cycle so that if it's a challenge in the family in this generation, such as diabetes, what can we do in our various programs to help break that cycle so it doesn't occur with the next generation? And that's that long-term piece that we work to assess. That can't really be done easily in a health system with addressing those medical needs. This is where we work to address those non-medical drivers that are often systemic and across the family and community environment. Thank you, Sarah.
And just to add on to what Mary said, it's not just it goes beyond that warm handoff. Family Service has met, all of the either social workers, nurse navigators that refer patients over to that team, and they, feel comfortable and empowered to message that case manager about, whether or not they've been able to make contact with the patient, or any maybe medical needs that the patient has communicated to the Family Service staff member that they may have not communicated to the case manager. So it's a very, strong relationship that we've built with Family Service. And so from the launch of this program through about the end of last year, we've referred over 401 individuals to Family Service. And of those, 220 received case management from Family Service. With that, over 435 pathways were created. And again, remember, a pathway, there's one pathway for each NMDOH need. And so knowing that many of our patients are suffering with 2 or more NMDOH, they may be enrolled in different pathways. And so that's all quantified there. Many of the needs that our patients respond to are food insecurity and financial resource strain. Those are our biggest needs our patients tend to face. And our patient population really lies within that 40 to 59 age range and 60 to 79 age range. And the majority of them are English speaking. When reviewing the actual needs that have been addressed. You'll see, again, financial and food are our two pathways patients typically receive assistance for. Those are the ones that they request assistance in. There also are two pathways that have the most patients that have graduated and completed the program. I forgot to mention this earlier, but within Compass Rose, anytime a patient accepts assistance, they're enrolled in the program. When the patient has had their needs met, they are then graduated from the program, and all of that is visible within the patient's EHR. And so, as you can see, housing and transportation, again, those are two needs that our patients did not screen positive for as much as food and financial, but they're also the two needs that our patients decline assistance with the most. That we have a really big housing problem here in San Antonio. And so sometimes when we refer a patient over to the family service for a housing need issue, they think family service is going to get them into an apartment, which unfortunately, that's just not how we can address housing just currently here in San Antonio. And so when they hear, oh, you're not going to get me into an apartment, you're not going to get me into my own house, they typically may decline assistance addressing that need. But for the most part, we've had 172 pathways closed. Basically, the needs were met for those patients. 200 of those pathways were closed, but due to us being unable to contact the patient after some time. And so I want to highlight that we still count those as successes, because those patients, we actually enrolled them in a pathway. They were followed. They did receive some sort of case management assistance. They were connected to some resources, but just over time, they may have fallen off and no longer responded to the team. And we do have a couple of pathways still open for those patients that were referred between October and December of last year. On average, it takes about 4.5 months to address a patient's need. That's what we're saying. That's the average length of time a pathway is opened. And we're currently evaluating the rate of hospital readmission amongst these program participants. And early signs do show that patients who receive NMDOH case management do have a lower rate of hospital readmissions compared to those who do not receive this case management within those patient population groups. Now, this whole program didn't come without its challenges and lessons learned. Some challenges are, it's a very lengthy process to grant, outside individuals that aren't from the health system access to Epic. It could take anywhere from 2 weeks to a month and a half to grant individuals access. There's a lot of paperwork, and then just going through our data security process. This again is very new. Staff members from family service may not, have prior knowledge of working with an EHR. They're not within our clinics constantly using the EHR. So, it's a totally new program for them that really requires continuous oversight and training just to make sure that staff members maintain that system proficiency. They're documenting accordingly, and that they're familiar with the constant updates that come through our EHR. We've also had a high rate of attrition among patients referred to the program. As you can see, we have a little bit over a 50% acceptance rate to receive family service case management after the patient's been referred to family service. And that's just, the patient may have told their case manager yes, but by the time family service reached out to them, they may have forgotten, or they may not want assistance anymore. And so we've worked, though, with family service hand in hand to kind of address that attrition, whether it be the staff members reaching back out to our case management team after, their second attempt of trying to contact the patient to remind the patient, hey, family service is trying to get a hold of you. Please answer their call or their text message that's related to those NMDOH we screened you for. Staff turnover, again, we've had some turnover with family service staff. However, we are, we ultimately always get back to being fully staffed, but it does take a toll when it comes to that lengthy process to get them access to Epic, then getting them into Epic training, and then starting to train a whole new team on an EHR. So again, it can be a little bit of a challenge when it comes to staff turnover. And then again, this is a new program for both of us, both family service and university health, working with a community-based organization at this level. Whereas before, we may have had different levels of engagement with community-based organizations, but none as integrated as this. Some lessons learned. An NMDOH program like this takes time to build. As you all can see, we started our NMDOH task force back in April, but it took us all through October just to have all the processes in place in order to launch. And then it's key also to have all the stakeholders in the room during development. Family service had representation in all of our work groups. Our Epic team and quality team, everyone is aware of family service. They feel comfortable in reaching out to family service. Family service feels comfortable reaching out to them as well with any questions, concern, additional training request as well for the staff. And then we have this understanding that this must be an investment and not a partnership. And a partnership, not solely transactional. Mary, do you want to add anything to this?
Yeah, I think that key part about being an investment, community-based orgs, they rely on grant funding and a lot of times inconsistent funding streams. So being able to have this as a true investment and partnership working together, because community-based organizations understand their communities that they serve. They are there day in and day out. Your patients are not in the hospital day in and day out. They are out in the community. So just doing a referral and hoping something happens is one thing, but then being able to have that real partnership and investment in that and ensuring that there is funding support to make that occur is critical. And Sarah, actually, I was looking back at the 2 slides previous, the non-medical driver needs addressed here, in creating this, and yeah, right there, is in this partnership, it's really building relationships. If you're thinking the healthcare systems, they're used to dealing with the patients when they come in the door, as I said, and focusing on what's happening, what's being presented to them, and how do they meet those needs. They are not used to always thinking about, well, who outside the hospital should be engaged in this patient care. That multidisciplinary, interdisciplinary model is still within a healthcare lens on that. So building a relationship with somebody outside of the healthcare system, that is a big leap of faith. And takes time to build. Many community-based orgs don't appreciate their role in affecting long-term health outcomes either. They see themselves as addressing a need in the community with the people that they serve. So it's helping them to be educated and aware. And then the next piece of that is patients over the past years, they're not used to being asked questions other than like, what's your pain scale today? And, oh, you shouldn't smoke, oh, you shouldn't drink, oh, you should lose weight. But they don't really get into other non-medical drivers of health. So understanding from a patient perspective that those are hard questions now being asked, that does take time to build up trust and relationships. Well, why were you late to your appointment? Why are you not being compliant with your meds, et cetera, et cetera? They may not want to answer those questions out there. So having this true partnership and referral, which goes now on to the next slide, is building that relationship within the community so that the orgs that are out there day in and day out with the people that they serve are there. So why should you partner with a community-based or social service organization? First off, they are already trusted grassroots organizations, deep community ties. People are going to see them right now, especially folks that don't have access to healthcare on a regular basis or don't have trust in the healthcare system as a whole, which we know, is a valid point for some communities as well. So they can help build that relationship for you with helping people get access to healthcare. They're also experts in addressing non-medical drivers of health, whether they realize it or not. And it's how to get beyond addressing today's need, making sure that they have food on their table today or have a roof over their head tonight. It's how to get to those root cause barriers as to why are they consistently relying on food pantries and consistently housing insecure. That's where community-based orgs really work hard when they are working, in their niches here. They also are used to advocating for your vulnerable populations and helping patients and their clients in the communities to navigate complex systems. When people are struggling, that is not something that is even people in healthcare, that is not something that is easy to do, is to navigate our healthcare systems here. So your community-based orgs can help in that. They also have to operate efficiently because nonprofits tend to have very limited funding. Those community-based orgs, as I mentioned, rely on grants. And so they've got to be able to braid and blend and stretch those pennies, not just dollars, as best as they can to meet those care needs here. They also can help be an extension for you and helping to enhance your care coordination, those referrals, and those outcomes tracking here. They can build those relationships. They can be out there in the community for you to do things and help work with your patients in ways that your staff don't necessarily have time to do, nor is that a capacity that you necessarily want to try to build for them. These community-based orgs like Family Service can help you reduce delays in patient care, whether it's access to care, compliance, etc. Ensure that people understand the importance of screenings and prevention and treatment, etc. And thus help avoid and prevent avoidable high-cost utilization of care, whether it's readmissions, whether it's using ER as your primary care base, etc., etc. And then also community-based orgs, they can help offer insights for you into those correlations between what's going on in the community or in their home that's affecting a non-medical driver of health that is now affecting your cost of care and those high-cost claims with people that continue to come back in as a revolving door in ways that they could have been met at a lower level of utilization management or supports or prevention, so that their healthcare needs don't progress to a higher level if you could have nipped them in the bud early on. Thanks, Sarah.
And I know we are just about out of time. And so we know that this model, may not work for all community-based organizations. So at this time, as we're looking towards the future, we're looking at leveraging tools such as Epic Link as a referral tool for community partners. This is something that we typically use for skilled nursing facilities and long-term care facilities. We're also hoping to optimize the space at our new University Health Vita, which is going to be a state-of-the-art multi-specialty health center, which will have spaces to really drive innovation and collaboration between community partners. We're also looking at how we create pathways to partnerships with community-based organizations and who we consider partners and what a partnership really means, whether it be, they're a referral partner, they host classes within our community spaces, or they co-locate within our facilities like University Health Vita to address our patients' needs right there as a one-stop shop. That, we'll open it up for any questions.
Thank you so much for that presentation. If you've got a question, please drop it into the chat or raise your hand and I'll be monitoring it. There's a couple there already. There's two questions about the type of workers for family services. Are they certified community health workers that you use to close these pathways?
Great question. And I'd also quickly like to give a shout out to Gudelia Ramon. She is our new director of our program here at Family Service. And we are not using community health workers at this point. We felt that with the needs that we have with University Health and the types of services, we actually are using social workers. And so in that, they've got that higher level of skill set, education, experience, to be able to work more intensely with those needs. Over time, we could potentially add in community health workers. We do have promotores in some of our other programs that could be in support of, but the program that we have specifically that is our portal connection for University Health, they are all social workers and a data manager to help with managing the data.
Great, thank you. Robin Smith, you had a question about engagement. Do you want to unmute yourself and ask your question?
Saw your slide as well that talked about the number of families who decline services. We just find a high percentage of our families, they may screen positive, but when we reach out and try to talk with them and visit with them about resources and connecting them, they're like, oh no, I didn't mean to hit that as a positive, or oh no, I'm good, I don't have any needs. They really just kind of deny, minimize their needs. And I'm just wondering if you've had any lessons learned to get them more engaged. We use community health workers, but we also use social workers too. So, you know, I think we all struggle, all of us, no matter our skill, getting them engaged.
No, definitely great question. And so we do see that. And specifically with our transitions of care team, which is one of our cohorts that refers over to family service, those nurse navigators, as they're building relationships with the patient, they may even re-screen the patient for NMDOH once they've had that deeper connection with the patient, just because they do know that at times, you know, when patients are screened, you know, they're screened bedside by either a social worker or a nurse navigator. You know, that's the first time they're meeting with that staff member. They don't know exactly, you know, what food insecurity is, or they may not be comfortable sharing that information. And so that team actually goes back and re-screens the patient just to make sure, you know, that they are capturing any need a patient would have, and then refer them over to family service. And family service, because they do that, again, and it could be screening burden for the patient, but they do a more extensive screening for SDOH. They communicate that information back to us, and they may identify more needs that our social worker wouldn't have identified bedside.
Absolutely. And Robin, to add to what you were saying, absolutely true. We see that with this and with some of our others. But, you know, when the patient is referred over to us, sometimes we have trouble at first connecting. Either their phone numbers have changed or they don't recognize our number. So we work to say, okay, the healthcare navigators from University Health will say, you will expect a phone call from family service. Please answer the phone or contact. And then we'll find out what's the best method you would prefer to receive information from us. Is it via text or a phone call, email, etc., to get the process started? What language do you prefer, etc.? And then when we receive that patient and make that contact, you know, we're going to go through our process. But first, it's building a relationship, because as you know, they may not be comfortable sharing that they're having these challenges. You know, that's sharing a vulnerability that a lot of people might be embarrassed or ashamed, or may not even recognize that that is something that could be addressed, because that is their normal. And you know, why should they worry about it? Because it's just the way life is. So we work to build that conversation and the relationship. And it's not a matter of like filling out a form. For us, it's really building a relationship through conversation, building trust. And as I mentioned, then, you know, we do home visits. So we go out and assess the home environment for that patient and for the entire family, so we can understand their needs. And we've had some of our social workers going out, and we'll realize that there's needs within the home that, you know, they had not even acknowledged or brought up or seen as an issue. And again, as I noted earlier too, is there might be things we can do for the patient, but a lot of times there's things we can do for the whole family or for the caregiver of the patient within the family, to be able to see what can we do, not just to stabilize you now, but to really work to address those root cause challenges. Some we can't address in these times, as Sarah mentioned, our public housing list, they can be several years wait for that. But what can we do to help get them through that really complex paperwork to get them on a list that they may not have been able to do on their own, or access benefits that they didn't know they were eligible for, or how to fill out. So we'll work on those pieces while we're working with everything else. But it all starts with that trust and that relationship. And the thing too, with the patients that are referred to us, now they know that even if it's a need that, you know, we're dealing with now, and then we stop seeing them now, if they want to come back to us in a year, 2 years or now, they now know who we are, and they know that we'll be able to help them at that point when they're ready for that next step, and acknowledge that.
Well, I appreciate this discussion. I hate to cut it short, but we're coming up on time, and I'm going to turn it over to Jackie to close us out.
Thanks, Charles, and thanks. I agree. This was such a robust conversation. These types of convenings that we hold are critical to advance NMDOH work in Texas. Before we wrap up, I would like to do my plug for our program index and invite the health organizations, including health systems, hospitals, clinics, and health plans, who are offering patients non-medical services through their healthcare delivery system. We want to hear how you're meeting your patients' non-medical needs. This is a really exciting opportunity to showcase the various ways that healthcare is already addressing patients' non-medical needs in Texas. The index is a resource for providers to learn who is doing what for which patient populations. It can also be a resource for policymakers to see how the health system is meeting patient non-medical needs and make policy change in favor of sustainable payment. The program index is as robust as we make it, and I thank those of you who have reached out to me so far. I look forward to hearing from the rest of you. The link for the program index is in the chat. Please click on this link and bookmark it for when you can add your information. Thanks everyone for taking the time today to join us. Look out for the meeting materials in the coming day. We will also include a link to suggest ideas for future webinar topics and encourage you to tell us what will be useful to you and the role you play in serving the field of non-medical drivers of health. Thank you so much and have a great day, everyone.